Good morning, good afternoon, and good evening. Welcome to ICAP Grand Rounds. Um, I, I see we have at least 50 people. I assume a few more will continue to join as we get started. Um, Today, I'm very pleased to tell you that we're going to be speaking about Marburg virus disease. And just by way of introduction, know me, I'm Dr. Jessica Justman. I'm Senior Technical Director here at ICAP. So today we're going to hear about the Marburg virus outbreak status and response in Rwanda. Um, and we have really two really terrific speakers. So we're very pleased to be able to do this. Marburg virus disease, as many of you know, is a severe and often fatal illness that's clinically quite similar to Ebola virus disease. It's extremely virulent. It's spread between people via direct contact with bodily fluids and with surfaces and materials that are contaminated with these fluids. So different than COVID and all of the airborne transmission that we have been talking about with COVID. In terms of Marburg virus disease, at the end of September, on September 27th, the Ministry of Health for the government of Rwanda announced the country's first ever outbreak of Marburg virus disease. As of today, there have been 66 confirmed cases. The Rwandan government has been implementing rigorous testing, contact tracing, and isolation and quarantine measures to contain the outbreak, and we're going to hear about that in more detail. We have experts from the World Health Organization's Regional Office for Africa and the Africa Centers for Disease Control and Prevention, who will tell us about the current status of the Marburg virus disease outbreak across Rwanda, the response efforts, and the ways forward. And I want in addition to having this webinar sponsored by ICAP, it's also sponsored by the New York City Pandemic Response Epidemic. I'll be introducing our speakers in just a moment, and then we'll hear the presentation. I want to just remind you that if you have any questions for the panelists, to use the Q&A box rather than the chat box. The Q&A box is the best way to get questions to the panelists. And at the end, the webinar recording and the slides from the webinar will be posted on the ICAP website. So let's introduce our speakers. We're going to hear first from Dr. Marawi Araga Tegenye, and he is head of Surveillance and Disease Intelligence Division at the Africa Centers for Disease Control and Prevention. He's a medical epidemiologist and served as acting head of the Division for Emergency Preparedness and Response for Africa CDC for over 6 years. And he has more than 20 years of experience in public health surveillance, disease intelligence, emergency response, and disaster risk management. He also played a significant role in establishing the Africa CDC and served as a member of the multinational expert committee of the African Union to establish the Africa CDC in 2014 to 2016. He's a medical doctor. He holds a master's degree in public health and is a fellow of the London School of Hygiene and Tropical Medicine's executive program in global health leadership. So I think we'll hear from Dr. Marawi first, and then I will introduce Dr. Patrick, who is with the World Health Organization, after we hear Dr. Marawi's talk. So Dr. Marawi, please, if you would begin.
Thank you very much, Jessica. Good morning, good afternoon, all. Let me share my screen and walk you through the current Marburg disease outbreak response in Rwanda. So maybe I hope you can see my screen.
It looks great. Thank you.
Okay, good. Thank you very much again for having me here. Just to give you a little bit context about the Marburg disease outbreak, the disease was detected in 1967 from the the lab event in Germany by then. But in the continent, this is like since 1975, this is a 14th outbreak, and Rwanda declared it on the 27th of 2020, September 2024. And this is the first ever outbreak in Rwanda. But as you can see it here in the table, the last two outbreaks were in 2023, and the last one is in 2023 in Tanzania, which is in district bordering Rwanda last year with the Kagera district. By then, it was from March to May, it was contained, and it was aborted with 9 cases and 5 deaths. And the same year, in 2023, Equatorial Guinea was also reported Marburg disease outbreak, which we also hear from Africa CDC supported that outbreak response. So just in a nutshell, this is the first outbreak in Rwanda, and Rwanda has really managed it collectively with all other partners here. As of yesterday, 66 cases, confirmed cases reported with 15 days, and all people in isolation and treatment now are out, and 51 recoveries, and with case fatality of around 22.7%, which is the lowest in the record we have. As you can see it in the middle curve here, the number of cases over weeks, this weekly trend of MVD outbreak. It was first reported around early of September, which was detected later on a little bit late, but the outbreak was so really rapid and that contained within a short period of time. As of now, all cases are coming from the contact list. There was a really thorough contact listing, and unfortunately, 52 of 66 cases are from healthcare workers. As of today, 19 days and 35 days without case or no days, respectively. And all these cases are mostly adults. As you can see, all these are healthcare workers, and the age distribution is from 20 to 50. In that range, that significant number of cases are affected. And when it comes to by sex or gender distribution, more males are affected, and I will come later in my next slide to give you more context about why this has happened. So this is overall, there was a really intense investigation for finding out the index case. The case was reported in one of the best hospitals in the country, in the ICU, where there was this incident that happened in the ICU intensive care unit that they managed. That's why all these exposures are coming to for healthcare workers. So on the first curve that you can see, it, this is they try to map out and the index case, which is a 27-year-old male, has visited a cave that harbors bats, and he went to the ICU, King Faisal Hospital, and started that transmission chain. This, as you can see it, different colors, but a little bit blood. But this is different categories of people that have get exposure to this outbreak. So when it comes to the contact tracing case and contacts, and overall the cases are clustered around 3 cluster areas. The index case, the first King Faisal Hospital, which is where the index case came in, and that's the other hospital, which is a teaching referral hospital as well, where all these cases, and the blue colors are those contacts that were tracked from all these cases. The cases are labeled as the case 1, 2, 3, and so on. And quite a number of contacts were listed and were closely monitored and followed. Unfortunately, all the cases are coming from this contact list, and they were really managed very closely. And the index case investigation took clearly indicated that this was the overall the pattern that we saw from the case investigation is like it is within these three clusters. So when it comes to the MVD sequencing, 9 genomes with high coverage were successfully sequenced, including 6 with over 90% coverage. And what reveals is a single zoonotic origin, and that is which the outbreak sequence shared with a common ancestor with a sporadic case reported in healthcare worker in Kampala in September 2014. Which is almost exactly 10 years before. So this is the typical finding, what as a single zoonotic spillover of the case from the genomic sequencing. So when it comes to risk assessment in general, to see how the likelihood of spread of the disease locally, internationally, regionally, based on different factors, including because of the high risk of this pathogen, the risk of exposure and transmission is high, the severity of the disease with high case fatality and lack of pre-qualified vaccine and therapeutics and potential cross-border transmission. This was labeled as the risk of spreading locally is very high, and regionally was high in those days in the early phases of the outbreak. And we also try to do how ready are the neighboring countries for any potential spillover. What is their capacity, existing capacity at different pillars of managing this outbreak for any potential spillover. And we do assess, we did this assessment around the beginning of this outbreak into rapidly across the neighboring countries and as well as other countries that reported before. And overall finding of regional or countries' readiness for any potential spillover is not really promising. There are a number of gaps that we have noted, and overall capacity is 41.4%, which is far below than the expected, at least 80% and above that we were expecting. So this really calls in an intense containment measure within that country, or otherwise if it slips out, there will be a really huge impact or a huge undertaking that may be required to contain the outbreak before it goes out wild. So this was a readiness assessment that we did was for countries' preparation for any potential spillover, but it was handled at national level, which Dr. Patrick will give us more. And now the situation looks 0 cases reported for the last weeks. So it is almost now contained. We are counting down the days now. So this is, in a nutshell, a brief overview. Still, investigations are ongoing to find the origin, the potential zoonotic spillover, and across the country, and that is where we are. But it is where the current situation is. Thank you very much. Back to you, Jessica.
Great, thank you so much, and we have plenty of time for questions. But let's hear from our second speaker. We have Dr. Otim Patrick Kossi Ramadan, or Dr. Patrick. Dr. Patrick is a Senior Health Emergency Officer and Team Lead for Acute emergencies, as well as the incident manager for the Marburg response in Rwanda at the World Health Organization's Regional Office for Africa in Congo-Brazzaville. Dr. Patrick is a medical doctor with a Master's of Public Health from Makerere University in Uganda. He has extensive experience in infectious disease epidemiology, emergency preparedness and response, incident management systems, and public health surveillance in several countries, including Rwanda. And he's currently the Senior Health Emergency Officer and Team Lead for Acute Emergencies, and as I mentioned, the Incident Manager for the Marburg response in Rwanda for WHO. And Dr. Patrick, let's please let you get started. We're very eager to hear what you have to say. Thank you.
Thank you very much, Jessica, and thanks to my brother, Dr. Merawi, for laying the ground for this presentation. So I will, he has ably covered the initial part in terms of the detection and the surveillance that was done. I will then focus on aspects of coordination, clinical management, mental health and psychosocial support, and make some comment on the issue of research in the context of the outbreak response. One of the areas that we didn't, I thought maybe it was an oversight when we were identifying the areas to cover in the presentation, was the critical area of risk communication and community engagement. Personally, I'm very passionate about that area, though as an epidemiologist, but most times in different outbreaks, I spend a lot of time engaging with the communities. And we know outbreaks start and end in the community. So it's a critical area. And I just wanted to highlight that upfront. And we had a very good cooperation from the communities in Rwanda, both the healthcare workers that were affected, but also the general public. So it made the response interventions quite easy because of the general support from the public. So I'll just start moving on my slides quite quickly. So just trying to lay the overall framework for the coordination of the response. So we had a very good coordination that was stepped up, and it leveraged a lot the lessons learned from the COVID response, but also the capacities that the country has been building. And the coordination generally at the national level was aligned with the WHO architecture for health emergency preparedness, response, and resilience. So looking at emergency coordination, having a command center at the national level and command posts at the district level. The collaborative surveillance that Dr. Merawi has talked about, including the One Health aspect, and points of entry. There was a very stringent measure put in place at the airports, particularly for exit screening for people that were leaving the country, to ensure that contacts who are supposed to be monitored do not leave the country, or any symptomatic person. And then, of course, there was the issue of the safe and scalable care that I will talk about, the countermeasures and research, as well as the community awareness, which I was commenting on. So that was the framework. The organization of the response. So there was a very strong political and technical leadership of the response. So you have the National Epidemic Preparedness and Response Coordination Committee, which is chaired by the Prime Minister, which has overall oversight for the response. You have the National Command Post that was led by the Minister of Health himself. And then you have the district command posts that were established in the affected districts, and you have the typical pillars of a public health emergency response that was activated. Now, the national command post then had all the pillars, and working with that, we did develop a national readiness and response plan with the 11 pillars, and each of the pillars having some specific objectives that they were working to achieve. And this national response plan was the one which set out the response strategy and the priority interventions for each of the 11 pillars that were identified in the national response plan. Now, one of the things I wanted to highlight is that in the national response plan, we did have, it was a scenario-based planning which was done. And in the development of the plan, we looked at 3 scenarios. Merawi and myself on ground when this was being updated. We have the best case scenario, the most likely scenario, and the worst case scenario. And these were the considerations we had in the most likely scenario. He talked about the late delay in detection of the outbreak. We had, of course, there's high population mobility between Rwanda and neighboring countries. We had the fact that by the time the outbreak was declared, we already had gone up to 26 cases. So there was the most likely fact that there may be some unknown chains of transmission, and the CFR we had estimated would go beyond between 40 to 59. But as you saw, the final CFR is actually much lower than this. And we had estimated a response time of 3 to 4 months. And on the baseline of 26 cases, we had anticipated that there would be 52 additional cases that would take us to 78. But as you saw, the final case tally is 66. So generally, the most likely scenario held true, which was a very good outcome in terms of what we had anticipated in the planning. So the response strategy looked at strengthening coordination, leadership, and partnership. There was a very strong leadership, as I mentioned, at the national level and the district level, but also very strong partnership mechanism that was established, co-led by WHO and USAID, and as part on behalf of the development partners. But then we also had very strong backing from Africa CDC, and Merawi was supporting on leading the surveillance arm of that partnership. And then the work on enhancing surveillance and case confirmation. So we had teams that were deployed. Rwanda leveraged the National Field Epidemiology Training Program to really deploy boots on ground who supported the investigation. They were very, very instrumental in identifying the index case. And so they had very remarkable contribution to this. And then the testing being done solely at the National Public Health Lab, and decentralized additional 4 labs in the regions were activated to support the national lab. So at some point they were doing over 500 tests in a day, which was very remarkable at that point of the outbreak. Of course, ensuring safe clinical care and IPC practice, advancing research into vaccines and therapeutics, scaling up risk communication and community engagement, and ensuring continuity of essential services. Now, this was a critical aspect. As Dr. Merawi mentioned, the outbreak occurred in one of the tertiary facilities, the 2 leading tertiary facilities, and it impacted the critical care provision. And one of the priorities for the country was to ensure that more people don't die because they can't access the advanced critical care that these 2 facilities were providing because the outbreak started in the ICU. So sustaining the delivery of critical care was a major component of this response. And the minister did his best really to ensure that unnecessary deaths were averted, and which is something that I really salute him for. And this, so there were really 3 objectives. And when you have an outbreak and you detect the outbreak a little bit late, one of the things that people will start asking you a lot about is, the source of the outbreak. Where did this come from? But to give credit to the leadership of the Ministry of Health, these 3 priorities were identified, and in order of importance, starting with the issue of saving lives. So because we had started confirming these when healthcare workers were dying, and these were very senior, highly experienced clinicians. So the priority number 1 was to save lives. The second one was to stop the transmission, and then identify the source of the outbreak. And I must say that they have done really well in following these up. So quickly we're able to scale up capacity to save lives, and then working to halt the transmission. And then a lot of work has gone into the One Health investigation that Dr. Merawi was talking about. So let me then move on and talk about the clinical management. And it's been one of the remarkable areas of this response, as evidenced by the very low CFR, one of the lowest that we have ever seen, 22.7. And the mainstay of this was the optimized supportive care. As you know, the optimized supportive care has like 7 components. I may not have time to go through all of them, but it was really the critical in terms of systematic assessment of the patients, management of symptoms, and then rehydration, management of the glucose, availing clinical chemistry so that you can detect electrolyte imbalance and correct. And all these were really done. At the beginning of the response, there were some challenges, and you would see if you plot the CFR by weeks. In the beginning, the CFR was high, around 40 to 60%, and then it started dropping. And one of the things they did do was to collapse the clinical management to one treatment center in Kigali, and that enabled them to bring all the expertise in one place. But that facility also had significant infrastructure. It allowed them to have access to CT, access to ICU, and all these things really improved the care. So the optimized care, number one, comprehensive laboratory support. So all the lab that needed to be done could be done at the Baho Treatment Center, which was very, very unusual, and it has not been done in most of the VHF responses. And then it was a multidisciplinary response, so internal medicine, infectious disease, critical care, different aspects, psychological support. And then you will hear a lot that this was one of the first outbreaks for a VHF in which actually the patients were mechanically ventilated and successfully extubated after being on mechanical ventilation for almost 2 weeks. And there was nutritional support. They also had the clinical trial of therapeutics. And one of the things we did was to deploy some of the experts we have used in the different VHF outbreaks to work side by side with the Rwandan colleagues in the treatment center. And if you've managed these VHFs, you notice that, yes, clinicians are very strong-hearted people and they will want to go into the red zone, but sometimes having somebody who has done this before, an expert or somebody with experience, gives you an added confidence so that you can navigate through this. One thing I didn't add here was also the use of technology in terms of there were some robots that were deployed, which has communication interface, a video interface. So these robots can move into the isolation area in the red zone, and the clinicians can be able to interact with the patient when they are not physically in the room. So it reduces the amount of time that they need to be there when they put on the PPE, which sometimes can be very suffocating. So they spend less time. They just go in there to do the clinical assessment. They would have already interacted with the patient. So some of the quick observations included, as we know, MVD, as was mentioned, it's really a spectrum of clinical illness, starting mostly with mild and differentiated disease, the same thing we saw, fever, headache, lethargy, and then progressing on to multi-organ failure. Mostly it was the respiratory failure, but there were neurological, renal complications and thrombocytopenia that was seen, a number of abnormalities in the lab, but mostly thrombocytopenia, also the signs of hepatic injury. And there were a few cases, critical ill patients with anemia and some bleeding, which were successfully managed. And of course, there were secondary bacterial infections that were managed with antibiotics. So the infection prevention and control, really critical area since we had infection starting in a health facility. So focused on the ring approach. So trying around the cases that we had, the health facilities, implementing IPC and WASH, looking at the households and including the community. Even the community around the mine where the index case was identified, the IPC measures were also implemented in this. And this enabled the rapid interruption of the transmission. Of course, there were supportive functions like development of a national guidance, job aids, trainings, assessments and improvements using the multimodal approach. All those were being implemented. A key area was, of course, trying to minimize the nosocomial transmission. So in the treatment centers, organizing the flow, ensuring that the PPE are adequate and people are trained to don and doff appropriately, the injection safety, wash and environmental cleaning, very critical aspect, as well as the waste management. So my last two areas, one was in mental health and psychosocial support. This was a very important aspect of this response because of the sheer impact of the outbreak, including the deaths on the families, also the healthcare workers and the community. So there were three targets for this: the hospitalized patients, their families, and then the contacts who were in quarantine, as well as the communities from which they came from. So a lot of support was provided in this. Common issues dealt with included depression and some sleep disorders and anxiety, but it has been an area which there were not sufficient technical expertise to handle, but partners were able to surge experts to work with the colleagues from the government. And then on research, so Rwanda had actually been part of the WHO blueprint for priority pathogens. So they had already started working on some protocols from last year and identified PIs. So when this outbreak happened, we just accelerated. And with a lot of gratitude to the Rwanda FDA, they have really worked to improve their capacities. They did accelerated reviews and approvals. And so the government was able to get vaccine from the Sabin Institute, which was really used more in a single arm trial. But also the therapeutics was launched 2 weeks in, though most of the cases were already not there, but they have been able to enroll some patients into the clinical evaluation of the remdesivir and MBP 019. So as I conclude, I just had a few messages that one, as Merawi has mentioned, significant outbreak progress in the outbreak response. We have seen the countdown to the end of the outbreak commencing. We are now at day 0 plus 11. So we have a few days, weeks more to go to 0 plus 42. The focus now is on the patients that have recovered. As you know, there is viral persistence, particularly in the males, in the semen. So, and also, of course, there are some physical and psychological sequelae that need to be dealt with. I think one of the early things they are seeing is some of the people who have recovered coming in with some ocular complications that need to be managed. And then just my timer going off. So, and then the issue of IPC remains critical, recovery and rebuilding the system. I just wanted to mention that a good clinical outcome has really been a combination of factors: early detection, early initiation of aggressive supportive care, and the infrastructure that was provided in terms of the ICU and other lab equipment that helped to provide a full range of care. And I would like to conclude on the aspect. I always say that in emergency response, everything rises and falls on leadership. And in this response, we did see a very strong leadership at political and technical level, as well as the prior preparedness. There were a lot of capacities that were developed when other countries, including Uganda, Tanzania, had their own outbreaks. So Rwanda did prepare, and this preparedness was brought to bear during the response. So thank you. I will stop here and we'll be very glad to respond to any questions.
Wonderful. Thank you so much, really, to both of our speakers for such interesting and compelling talks. So we have a nice amount of time for questions. So we do have some questions in the Q&A box. I don't know, perhaps, Wafa, do you want to start off with a question? And if not, I'll take something from what has come in from the audience.
Yes, and again, I echo Jessica's comments and gratitude for these superb presentations. I have a question in terms of, the issue. Of course, you mentioned the importance of early detection of an outbreak, and I'm curious whether with the identification of the first case, which was at King Faisal Hospital, did the individual have contact with other health, facilities at lower level before coming to the large, of course, hospital? And the reason I'm asking the question is, we always think about the importance of kind of the value of clinicians the potential value of clinicians in being, aware of unusual presentations of illnesses and being able to kind of raise that red flag early on. So I'm just curious whether there was a trajectory from lower level facilities to the central hospital before the diagnosis was made or the diagnosis was suspected.
Is your question for Dr. Patrick, or I think
either? I think either of you. And it's just and it's also could be a general question about the importance of kind of the astute nurses and clinicians who are out there and their role in early detection of outbreaks.
Okay, thank you very much. I'll give it a try, and my colleague, Dr. Merawe, will chip in. I think the critical role of clinicians as frontliners in identifying outbreaks, I think, cannot be overstated. And one of the issues with the discussions we had in this particular one also was how we could have missed, or the system could have missed the first few cases before it was finally declared. But it wasn't unusual for most of the outbreaks. Marburg, it's always detected when healthcare workers start dying because of the atypical presentation, which is there in the early phases. So that is what we also saw in this, that the suspicion really rose high when deaths of clinicians in that ICU started happening. The second issue was that, and the minister had explained this quite a number of times, in Rwanda, the referral system is quite efficient, and the way their health system is structured, he said it takes less than 30 minutes to 1 hour for any patient in any part of the country to have access to the top facilities at the national level in Kigali. So it was really the same. If the person is being managed, which was this case for malaria or so, and they are not improving, it's quite easy for them to find themselves at the national referral or tertiary facilities. Now, so the first two cases, including one who was initially labeled as the index case and was later dropped. So most of them, they really could not have been detected because of the presentation. There wasn't really any significant hemorrhage. So it was very, very difficult, the index of suspicion, particularly considering that you've never had an MVD outbreak in Rwanda. So those ones were missed. But one of the clinicians was able to suspect that something was unusual when the other fellow clinicians started, like the first two cases that happened in King Faisal Hospital. Then they did request for a test to be done for viral hemorrhagic fever. So one of the things which we have discussed also with the minister is the need to be able to change the way we do surveillance in major health facilities. And he has hinted that they need to be able to even put in place a protocol for just routine sampling and testing for different panels of viruses or pathogens in the ICUs and other areas where critically ill patients are being managed, as a way of detecting early any of these potential outbreaks. Over.
Thank you.
Great. So let's see, we have a number of questions that have come in. One question is to ask whether the healthcare workers that were infected, were they all directly involved in the index cases care, or was there another source? I mean, I think you showed us the sort of diagram of the way the clusters were set up, but maybe you can just speak to that briefly again. Dr. Merawe, you're muted.
Yes.
Yeah.
Thank you. Thank you very much. That is a very important question. So in one of my slides, I show you the generation of cases that were coming. So as this is, I think Dr. Patrick already alluded clearly that The problem with viral hemorrhagic fever in our context is that detection usually mixed up with the differential diagnosis of other febrile illnesses, malaria, typhoid fever, and others. So we usually detect with clusters of diseases or any other hemorrhagic signs and symptoms. That is the issue and the problem. So when it comes to the cases now, these were the initial cases were cases that were in direct contact with those patient care, particularly those critical patients. And those people were also restating their fellow healthcare worker and so on. So then subsequently, that generation that I showed in the slide, and all these are under those contacts. And it's not like all 52 are from one single source, but it was a contact of contacts. That is a generation that I demonstrated in the slide. But the good thing is immediately everyone was listed as a contact and they were isolated and they were separated as healthcare workers and they were followed closely. And even though they still continue to practice, they were really, all those people with any patient care were isolated until this time, and they were managing. And I think that space was well controlled. Yeah. Thank you.
Great, thanks. Then there are a couple of questions focused on the community work that was referred to in the beginning, and maybe you can speak a little bit more to, what that involved and how was, all the stigma managed. And really, I mean, was sitting here and trying to think about, the on the ground experience in country, how was it managed so that the country could still go on and do all of the things it needs to do to keep its economy going, and not have sort of panic ensue, but at the same time, have people ensure the proper precautions. And, sometimes that can be a difficult, fine line to walk. So interested to hear about the management of the community work / communications on that.
Okay, thank you very much. There are two things that worked in favor of the faster control. One is that Rwanda has a very good community healthcare architecture. There are 2 to 3 community healthcare workers for every village. So they have almost 60,000 or so community healthcare workers across the country. And that was a network that was activated and largely relied upon. But there is also the governance structure with the municipalities and the local leaders who were fully involved in this. And it's also a very vibrant, you go to any of the local communities and each of the leaders at that level will articulate for you clearly what is happening in his community, and they know almost everything that goes on there, and they are very much in touch with the population. So those two were key factors in what happened at the community level. So you had the activation of the community healthcare workers. So there was active case search and the visits to households that was happening by these community healthcare workers across the country. And it was not only limited to the 3 districts of Kigali where the outbreak was happening. So this was happening across all the country. And they were very critical in passing messages, in also following up contacts and ensuring that they reflect or bring back to the leadership or raise up any concerns that are there at the community level, and they would pick up any suspected case if there's any. So that was the first line. Then of course the issue of the communication from the national. So there were regular briefs by the minister trying to explain every Friday what was happening, but then there were also engagements by the local leaders trying to pass the messages for prevention and control to the communities that were affected. Now, we did see genuinely, of course, you would expect that concerns from the communities, particularly where cases have happened and where people have have died, and there were some challenges in terms of reintegration of some of the patients that had recovered into communities at the early phase. And that's when the work of the mental health and psychosocial pillar was activated fully. So they had visits to the communities, they had counseling and health education and frequent engagement, even sometimes through phone calls with the community or the families that were affected. So it helps to manage the both the anxiety and the fear that was there, but it also helped to manage the issue of the stigma so that we didn't see it spiraling, and there was a smooth integration of the people that were being discharged from the treatment center. So it's ongoing in terms of the continued mental health and psychosocial support to particularly the families that were affected, but also communities from where the cases were picked up.
Question, maybe Jessica, and this might be for Dr. Patrick, is, the issue of the post-disease manifestations is interesting because, as you recall, with the Ebola outbreak several years ago, there was for the first time the detection of actually the virus itself post-recovery from certain body fluids, as well as also some post-disease or post-acute disease manifestations like ophthalmic, ocular manifestations, and so on. So it's interesting that you hinted at potentially also we're seeing this with Marburg as well.
Yes, so we had already concerns from the beginning that having learned from the recent outbreaks, both the Ebola and also the Marburg, that there is need for a very comprehensive program for follow-up of the patients that have recovered. So in other countries, we call them survivors, but in Rwanda, because of the context with what happened in 1994, so we don't use the word survivor. So that's why you've been hearing me talking about the patients that have recovered. That's the terminology that we have adopted as guided by the ministry. So in designing this, one of the aspects was that we will have a proper follow-up clinical assessments on regular basis to try to quickly identify any of the sequelae that may come up, but also manage some of the ongoing residual symptoms that the patients may have. And so, yes, in the first week or so, the last week or so, actually, the most of them were recalled. They had a retreat organized by the government, and just trying to orient them in terms of conducting further health education, and also trying to explain, particularly to the males. You will see that we have a high proportion of males, the risks that are there with the viral persistent in the semen, and doing health education on how they need to do safe sex and hygiene after practicing the safe sex and all those to prevent the risk of infection. But then also they were doing further assessment, and during that time it's emerged that there's an increasing incidence of complaints around ocular presentation. So that's one aspect that is actively being worked on to try to scale up capacity to follow up the different patients and provide support for any ophthalmic need that they may have. So it's still early to be able to describe in full detail the manifestations that the patients are presenting with, but one that has come up quite prominently is the ocular complication. Yeah.
Great, thank you. There are a few questions about the source. Are there any environmental interventions possible for the cave where the bats are? Is there a way to minimize human-bat contacts? Anything else that you might be able to tell us from that One Health perspective? That would be great for either of you. Oh, wait, we have lost Dr. Marawi. Okay, I hope we'll get him back. But in the meantime, then, Dr. Patrick, if you could take that question.
Okay, so the One Health investigation has been ongoing. It has been a joint with the colleagues from the wildlife, and as mentioned, there has been systematic tracking and trapping of bats in the cave which was identified, or the mine where the index case worked, and there have been collection of samples from those bats, and that's why they were able to identify that this was a single zoonotic spillover, because there was some of the bats from which the virus was isolated. And efforts have been done now to try to mitigate that risk. So that mine has been closed off where the bats were. And then the efforts that are ongoing, which Merawi would have talked about, is really trying to expand that ecological surveillance and try to pick different bats and test to see in terms of the proportion or the geographical spread of the virus among the bat population. So that is an ongoing work, and it's a critical work to be able to mitigate the risk. So far, I don't think other than that cave, they have picked up information on any other, but just from a point of view of safety and mitigating any other risk, they are continuing with that ecological surveillance and trying to capture as many bats as possible and test.
Great. And Dr. Marawi, I didn't know if you wanted to add anything about the source, sort of from that One Health perspective.
Yeah, thank you very much. Apologies, I was kicked out of this network. Yeah, I think maybe Dr. Patrick has already mentioned that, this investigation was really intense in a way that from identifying the index case down to investigating as One Health, investigating the environment and the caves. It was really an intense work that has gone into from medical record review to find out the index case, then go back to the caves, and they mapped across the country all the caves and potentially those harbor the bats, potential bats, and they really did great work and identified over 150 caves, of which over 60% have such bats. And they also put a risk category based on the presence of bats as well as human activity. And they did investigate. The investigation is still ongoing with the bats, but all those people that have been close contact with the index case has been tested, and one was found positive and he was recovered and discharged. So this investigation now currently the bats investigation is ongoing, and which is really a lot to learn from. And unfortunately, these bats really live across this region, across the continent, and it extends back to the Southeast Asia and so on. It is widespread, and they're closely monitoring that one. The one that was having the index case is now closed, and still that investigation is ongoing. Thank you.
Great, thank you. There's a question about protecting the health workforce. Can you comment on one or two top lessons that were learned that Rwanda and other countries can use going forward to minimize health worker risk?
Maybe let me come, but Patrick will.
Yeah.
I think, as I said earlier, really one of the critical things, especially with viral hemorrhagic fever, is late detection because of all other the shared signs, symptoms with other differential diagnoses. So really the base of all this is to do standard infection prevention and control practices, which we are really encouraging and also rolling out currently with ongoing training activities by multiple partners on infection prevention and control, revising the national guideline for infection prevention and control, and enforcing that infection prevention and control guidelines and strategies across all the health facilities. Furthermore, availing personal protective equipment and supplies to the health facilities is another area. I think maybe Dr. Patrick will mention a huge size of consignment was delivered to support that from the WHO. So, bottom line, moving forward, I think one of the recommendations that is coming out is how can we really map out regions with high potential for viral hemorrhagic fever and create that awareness and consciousness of healthcare workers regarding infection prevention control, differential diagnosis of any potential for any fever investigation, and also moving forward, setting up such a triage system for practically for protection of healthcare workers, in the meantime, early detection of the outbreak. So let me stop there. Patrick, maybe if
yeah, just maybe Patrick, just a half a minute response, and we'll try to maybe squeeze in one more question. Otherwise, we'll have to wrap up. Go ahead.
No, I think that Dr. Merawe has ably covered that topic. So yes, we can.
Okay. The other question was just if there's any quick comments on how effective remdesivir was. Any early signals that you can comment on? Does that seem to be helpful?
No, I will not be able to comment on now. One of the things was that though it was also part of the clinical trial that was initiated, but at the early phase from the onset of the response, there was a decision made to administer it to all the patients, just as part of the standard package of care.
Yep.
So unless we are able to, have some data, it will be difficult to just.
You don't have a control arm. I understand.
Yes. So it will be difficult to talk about how effective it was, but it was part of the standard care.
It's part of the package. No, it makes total sense. Okay, well, thank you to both of our really fantastic speakers. I think we've really enjoyed your comments and the robust Q&A session. Excuse me. So I just want to thank everybody and remind you that the webinar recording and the slides will be posted at the ICAP website. Thank you very much, and enjoy your day and stay safe.
Thank you so much.
Thank you.
Thank you.